Hello.
We can start soon.
A very good evening to all the respected audience that are present today on this virtual platform of Zoom to commemorate the World TB Day, which falls tomorrow exactly, March 24. Each year, we commemorate this very day to help eradicate this very menace of TB, because we know its social, economic, and health devastating consequences that the disease has on mankind. For the past couple of years, the end game for TB has been very difficult for us in the context of COVID, but still we are fighting. The clock is ticking away. Our target is near. We have to work hard hand in hand to bring down and eradicate this devastating mankind's curse, which is known as TB. It's my immense pleasure on behalf of IAP Thrissur to invite you all once again this
94.
Let me specially invite our respected TPS for today, our district TB officer of Thrissur, Dr. Suja Aloysius. Madam has been kind enough to join us today to inaugurate today's session. We have none other than two great speakers who are real legends and the authorities on tuberculosis. My teacher and mentor, Kesavan sir, needs no introduction. Sir is the word for TB in IAP Thrissur. Sir is leading the committee on TB and has done immense work for pediatric TB and its eradication. He is the key person in formulating of guidelines for pediatric TB and LTBI in Kerala, for Kerala IAP, which has been accepted by the national, central NTP program. Welcome, sir, to today's program. Next, I invite respected Sanjeev, sir, additional professor of pulmonology, Government Medical College, Thrissur. Sir is again another key person in the formulation of the guidelines, and he plays a very important role in the program, NTP program that is placed in Kerala. And with great pleasure, we know today that Kerala has been awarded the bronze medal for the TB eradication programs that we have here, and sir has due credit in it. So we welcome you, sir, to our program today, and I'm sure.
Manjusha, you are muted, Manjusha.
Unmuted.
Sorry, sir. I also invite our respected Vice President of IAP Kerala, Dr. Mukesh, sir. Sir has been a pillar for us, for IAP Thrissur, since long, and we are proud to have a Vice President among us today. Sir has been a support for all our programs. Our respected President, Reddy Madam, will be joining us shortly. She's not been able to join due to some technical glitches on her part. So without much ado, we'll have her presidential address once Madam joins. So I invite Dr. Suja Aloysius, our district TB officer, to inaugurate today's session.
Reddy, can you present the address? Yeah.
Madam, Reddy Madam?
Yeah.
But I invite you for the presidential address.
Unmute.
Madam, you are muted, madam.
Unmute, madam. Unmute.
Madam, again you are muted, madam. Oh.
Yeah.
Madam is joined with two devices. That is the problem. Two devices. Switch off the other one.
Madam,
You can just tell a few words.
So good evening, everybody. I've solved out the technical errors. So today our meeting is held to observe a very important day. That is World TB Day, which falls tomorrow, March 24th. That historic day when Robert Koch discovered a tiny mycobacterium that creates havoc. It is tomorrow. To me, detecting TB in olden days was a proper history, a Mantoux testing, sputum or gastric lavage, and X-ray. But gone are those days of relying only on Mantoux testing. So there are many more tests now which can help a clinician now to go along the proper path of detecting. So today we shall hear two excellent speakers talking on the newer diagnostic methods of TB detection, and Dr. Ananda will talk on how we can look just not on the hilar node, but in X-ray, there are much more than what just meets the eye. So waiting to hear your talk, Dr. Sanjeev Nair and Dr. Ananda. We are privileged today to have with us the District TB Officer, Dr. Suja Aloysius, for the inauguration. Members, last week we have observed the Down Syndrome Day with enthusiasm and vigor with various events, including the Zoom meetings with caregivers, as well as physical meet and academic sessions. Coming up next is our monthly meet on 6th April. Actually, Autism Awareness Week is from March 29th to April 4th, and the Autism Awareness Day is on April 2nd. But since it coincides with many holidays, we have decided to club it with our monthly meet. So for the meet, we have the speaker, Dr. Sebind Kumar, psychiatrist from the Government Medical College, and his wife, Dr. Danya, psychologist from Thrissur Government Medical College. So members, please do join in for all these meetings. And we go on to the next session, which is very important, the inauguration by our dear District TB Officer, Dr. Suja Aloysius. Over to you, madam.
Thank you, madam. Respected Rezi Madam, Ananda sir, Sanjeev sir, and all dignitaries of the IAP Thrissur. Thank you all for inviting me to this CME on TB on the eve of this World TB Day 2021. First of all, as the welcome speaker said, the clock is ticking. That you all know that we have no time to waste. We have to move faster in diagnosing each and every patient, whatever the means may be, following the diagnostic algorithm. We can't have any delay in the diagnosis. And so I think Andarshan sir is speaking on that topic basically on X-rays. And the newer updates by Sanjay Nair sir from the Government Medical College, both faculty from the Government Medical College. And as you all know, as the welcome speaker again said, the COVID-19 pandemic has posed a serious challenge to TB also. Many of you might be thinking that mask has helped a lot in spreading the disease. It might be true because when compared to that of the 2019 statistics, we had a drop in around 450 cases notified in 2020. We don't know whether they are missed because the drop was around 358 microbiologically confirmed cases actually, including both pulmonary as well as extrapulmonary. So we have to move faster, diagnose the cases more, detect the case more fastly, earlier. So 2 or 3 things I have to specify. First is, in diagnosing a case, I request the help of pediatricians to make a microbiological confirmation. Because in the COVID-19 pretext, we had installed NAT services in all the taluk levels. We can offer microbiological confirmation through molecular testing by NAT We have around in the medical college also, in district TB center, as well as in Kodingalur, Chalakudi, Chavakad, Vadakka, in all the taluk levels, we have installed NAT services. So try to make a microbiological confirmation of all pediatric cases you are treating. Because in 2020, only around 5 cases had microbiological confirmation. 95% were clinically confirmed cases. In the move for elimination, we need a much more stronger confirmation, a microbiological confirmation. That is the first point I want to stress. The second one is, if you diagnose a case, whether it might be microbiologically confirmed or clinically confirmed, notify the case. That it is mandatory to notify each and every TB case. We might be missing the case because they are not notified. And we are now having a strong H1 drug schedule surveillance also, through which we can find the missing cases which are not actually notified. And in notification, the NTP Thrissur will assist you. If you have any difficulty in notification, NTP Thrissur will assist you. And third most important thing is the fourth phase of Kerala TB elimination mission, that was LTBI management. And Thrissur has started IGRA testing also. And we have already done around 44 tests, 12 positives, two started on 3HR, and the rest 10 waiting for the baseline investigation. They're on their baseline investigation to rule out the active TB. So I conclude my speech. I inaugurate the CME, and I'm very happy to have been here to inaugurate the session. And thank you all, office bearers and all faculty of the IAP Thrissur, for including joining hands with NTP Thrissur in the fight against TB. Thank you.
Thank you so much, madam. Before I invite Dr. Mukesh, I have to inform one more upcoming event that is on Thursday, 25th March. We shall be having a very good session. That is, we have our I-Square, that is infection and immunization series. So we have two excellent speakers. One is Dr. Keya Ghosh Uttam, who is in charge of NICU at the Institute of Child Health, Calcutta, and she'll be speaking on the judicious use of macrolides. And the next one by Dr. Danya Dharmapalan, who is a consultant in pediatric infectious disease at Apollo Hospital, Navi Mumbai. Very important, improving antibiotic use in daily practice. Okay. Now, for the next, I invite Dr. Mukesh for a felicitation.
Respected President Reddy Ma'am, Professor Ananda Kesavan, Professor Sanjeev, and all the dignitaries, and my dear fellow IAPians. First, let me congratulate IAP Thrissur for conducting a CME on tuberculosis to commemorate World TB Day that falls on tomorrow, 24th of March. And I wish a good success for this program and all the best. Thank you.
Wait.
Next is Dr. Srijit will introduce the moderator and the speaker.
Thank you, Reddy Madam. So now the inauguration ceremony is over, and now we will move on to the CME part. We have two topics today, and the first topic is that the what is new in TB diagnosis and treatment. And for this, we are very fortunate to have a real expert in this field, Dr. Sanjeev Nair sir. And Sanjeev Nair sir is a additional professor of pulmonology in pulmonary medicine in Government Medical College, Thrissur. And sir's primary area of interest is tuberculosis and tuberculosis research. And sir is a chairman of State LTB Infectious Working Committee and a expert committee member of numerous scientific committees like difficulty to treat TB of Central Division of TB India, and is also an expert committee member in the development of guidelines for the management of drug-resistant tuberculosis and National Tuberculosis Elimination Program. And he is also a WHO consultant for RNTCP. And to list the achievements, there's numerous achievements, and it will take at least 10 minutes to describe all these achievements. And to say that, to make it short, he has 43 publications in national and international journals, and including the prestigious Lancet. And Sir is currently doing research on CTB, and is doing this work will come soon. So with this introduction, I will invite Dr. Sanjeev sir for the talk, sir. Over to sir.
Thank you so much. Am I audible?
Yes, sir.
Yeah, audible.
Yes. Yes, sir.
So I'm very thankful to Dr. Sanjeev Nair because he accepted our invitation at a short notice. I informed him 2 days back only, and we'd like to take such an excellent speaker. Thank you, Sanjeev.
Thank you, Ananda Kesavan, sir. I've been working with Dr. Ananda Kesavan for the last 20 years. So, when he makes a call, it's an order for me. So I accepted the invitation. But after I accepted the invitation, I was a bit confused because I was honored that the IAP leadership chose this topic and also invited me for the talk. But it's such a vast topic that, what is new takes a lot of time to cover. I consider a lot on, leaving out certain things and keeping in certain things. But at the end of it all, it's a pretty long presentation. So I would request that you excuse me if I rush through a bit. I'll be skipping a few slides to keep to time. I kept a timer there and hope to finish sharp in 25 minutes and not delay Dr. Ananda Kesavan's talk on that. So basically, World TB Day is coming up. It's an important day for all of us. We have been observing this day for, I can't say celebrating, but it's observing this day for the last so many years, maybe 25 years. This slogan by IAP really caught my attention. TB-free air for every child in Kerala. This was the one that we discussed a lot when IAP sat down to make the latent TB infection guideline inaugurated. Extremely catchy, and even the health secretary and the health minister, everyone was impressed by this. But then during that meeting, I said, that if you need TB-free air for every child in Kerala, it is basically the adult pulmonologist who will have to do his job rather than the pediatrician, because the air is, made full of TB bacilli by the adult patients, and the work is all with the adult doctors who treat the patients with TB who are infectious. Also, like a lot of speakers already mentioned, the clock is ticking. As you would see in the coming slides, we have a lot of things that we have to do by 2030, 2035, and the clock is really ticking, and we really are not sure whether we'll be able to meet those guidelines. So there's a lot of urgency in what we want to do. So basically, the plan for today is just briefly discuss the changing epidemiology, because that has a lot of impact on what we are going to say and what we're going to do. Also discuss a bit on what is new in diagnosis. You all would be aware of the new tests which are there, but I hope to discuss those tests, the positives and negatives, with a pediatric diagnosis point of view. Discuss briefly, rush through what is new in treatment, because it's not really new. I mean, it's been there for the last 3-4 years, but MDR-TB treatment obviously is changing, but that is a very small number. And then not discuss LTBI treatment or TB preventive treatment in detail, because that has been discussed a lot in your training. So maybe 1 or 2 slides on that. So going on to the epidemiology and strategy, TB still remains a major problem. The number of cases with TB and the number of deaths due to TB definitely would have gone up this year because of the COVID scenario. We would only know the figures later. A large number of MDR-TB and HIV-TB complicate the situation. And unfortunately for us, except for HIV-TB, we are the leaders in the world. Almost 1/4 of all of these type of cases in India. It's just in HIV-TB that we are slightly behind certain other countries. The strategy has been evolving. The Stop TB strategy, which we were working with, ended in 2015. And by 2016, we moved to this new strategy called the NTB strategy, which is pretty ambitious. And this strategy looks at, reducing incidence by 90% and mortality by 95%, which is a very tall ask. by 2035. I mean, person like me who has been working with TB control for the last 20 years, the moment I saw this, I got frightened. How are we going to do it the next 20 years? But if that was not enough, our health minister, Sri Harshvardhan, Dr. Harshvardhan, in fact, medical doctor, went to the World Lung Conference and said that India will achieve the 2035 targets by 2025. We will do it 10 years ahead. So, since then, every government in India has been saying that we'll do it faster. So the clock is really ticking for many states and the country, because we have preponed our targets. And it's a very difficult task, a lot of things to do. And if you look at the red line there, that is the current slope of decline. And we really need to bring it down much, much further. The district TB officer and some of the other speakers mentioned about the award that Kerala state got. So that award, was given because our decline is somewhere around 7%. So which is a big decline. No other state in India has a decline like that. But even with a 7% decline, that would not be enough, because during this period, the decline needed was minus 10%. And, to actually achieve the target, you need a minus 17% decline. So decline has to be much more steeper if you really need to achieve those targets. So that is how it goes. A difficult thing. And with respect to pediatric TB also, the world has been doing a lot of things. I don't have too much of time to discuss many of these, but a lot of new documents, all of these documents are available on the WHO website, easily downloadable, freely downloadable. And they talk about a roadmap towards ending TB in children and adolescents, which is much easier than ending TB in adults, because it's a population which can be much easier addressed. So this is something that the world is looking forward to, and definitely something that we should also look forward to. With respect to childhood TB is bleak. Still 1 million cases every year, which is about 10% of the total TB cases in the world. Out of the 10 million or 1 crore, about 10 lakhs or 1 million are the number of childhood TB cases. So generally all over the world, it is believed that around 10% of TB cases would be childhood TB cases. But if you look at the mortality is higher proportion when compared to the adult mortality. So it's 10% of the total cases, but it is almost like 15 to 20% of the total mortality. So the mortality in children is much higher than the adult mortality, which is a shame, because we have good drugs available. We can prevent TB in children. So if you look at the TB preventive treatment, which is in the last box, which actually reaches only a small proportion of children. So you can actually prevent TB in children, and we are not really working well towards it. Of course, we should realize that even when you have 1 million cases every year, about 67 million children are infected already. The 1 million is a disease. So about 67 times that number is infected. And even though I said that earlier that MDR TB in children is a smaller number, even that smaller number is about 25,000 cases in the world, which is not really too small a number. So that is also a challenge for many of us. If you look at the Indian scenario, in India, among the notified 24 lakh cases in 2019 in India, about 6.3% were pediatric cases, which is less than the 10% which is expected. So we always think in terms of in India is something missing. So a person who is a strong proponent of this is Dr. Soumya Swaminathan, who was the director DG of ICMR, who is now the deputy director at the WHO, made India proud because of women from India reached that way. She herself is a pediatrician. So a pediatrician who worked a lot in TB. She actually always tells me that, Sanjeev, we should be getting that 10% figure as the rest of the world. Why are we stuck at 6-7%? So maybe we are missing pediatric TB cases in India. But if you look at Kerala, the percentage is still lower at 5.7%. So, we need to wonder what is happening there. Thrissur is actually higher at 7.5%. But even that 7.5%, as we were discussing with the DTO, is that the right number that we should get? So, these percentages, numbers are there, the notified cases are there in front of us, but we really are not sure whether it's underestimate or overestimate, and we really don't know what is happening. Why do I say this? Because notification is now compulsory. The DTO did touch on this. So there are various laws, central and state laws, which has made notification of TB compulsory. And in fact, if I don't notify a case of TB, the DTO can report me and put me in jail. So there is also a penal punishment, a jail, punishment and a fine which can happen if I don't notify a case of TB. So it's a very serious offense not notifying TB. Now, there are many notifiable diseases, but in many other diseases, you can get away with it because, if I am writing a fluoroquinolone or if I am writing some other drug, it's very difficult to find out for what disease I am writing the drug. But when it comes to TB, the drugs are basically used only for TB. So if somebody writes INH, that person can't, escape by saying that I wrote that drug for some other disease, because the drug for TB, most of the drugs are drugs which are used only for TB. So there is a system now which the TB drugs have been put in Schedule H1 by the Drug Controller of India, and you can monitor the sale of the drugs, and that is also another way of looking at the notification. When you look at total notification in India, we made huge progress. So, as compared to 2012, when we were notifying only 14 lakh cases, and definitely a huge proportion of cases in the private sector were not notified, coming to 2019, where, you notified about 10 lakh more cases in the last 7 years. So it's a huge pickup in notification. And you can see that in 2012, the private sector notification was almost not visible, whereas by 2019, the private sector is notifying a lot of cases. So this is one area that we need a lot of introspection. IAP has taken up a lot of causes, and I have been a big fan of IAP. IAP is the only organization in India, the only professional organization which has sat with the Central TB division for the last 7-8 years and been making guideline after guideline. My own association, the Indian Chest Society, till date has not been able to reach that kind of consensus with the central government. Even the new president of Indian Chest Society, I personally took him and introduced him to the national program manager, Dr. Sachdeva, and they both had a very good conversation. They said they'll have a formal meeting, but it never happened. So, IAP is the only organization that does that. So one thing which is missing and which leaders of IAP can take up is the notification part. Because in pediatrics, often you're not sure of your diagnosis of TB. You think it's a kind of empiric treatment. So there is a worry whether I should notify or not. But it is very much possible to catch that prescription from the drugstore and find out that a pediatrician has not notified cases, which is happening in Thrissur, which is happening in many parts of Kerala. So that is something that can be easily taken up by IAP, and it's a need of the hour. Now, I was saying, are we missing pediatric TB? So there is one way of looking at it, that is the epidemiology of TB in Kerala. So if you look at it from 2005 to 2019, that blue line is 2019. So what you see is that TB in the older population is actually going up. The spectrum is changing, maybe NCD or increasing older population, whereas TB in the younger population in Kerala is actually coming down. So can we assume that TB in children is actually coming down? I always tell my pediatrician friends that if I do a good job, you will not see any TB cases anymore, because I will take care of the adults properly and no children would get infected. So that is the ultimate aim of any TB program, that the adult patients are treated so well that the pediatrician has no TB to treat. That is the ultimate aim of it all. But I mean, have we reached that epidemiological stage where you see less of TB? I mean, it needs a bit more of introspection and research to find out whether that is happening. So with that, I'll move from the epidemiology to the diagnosis. So if you go to the diagnosis of TB, from 2010 onwards, 2008, in fact, from 2008 onwards, there's a rapid advance. By 2008, 9-probe assay was available, became available in Kerala very soon. By 2010, Gene Expert became available, which again became available in Kerala and other parts of India very soon. The most recent test which we have got is the TrueNat, which is an Indian test, a very good test, and that is also readily available for us. And the number of machines available to the district and the state has gone up in huge numbers. So, we do have access to these tests. But we were talking of Robert Koch, and Robert Koch is famous because, it's not the day he discovered, but March 24 is the day when he declared to the world that he had discovered this bacteria, which is an age-old bacteria. I mean, the bacteria was there for the last 5,000 years, but somebody found out that this is a cause of tuberculosis only when Robert Koch actually saw the bacteria. So for years and years, for the last 100 years plus, detecting this bacteria was the main test for TB. Even till 5 years back, even for a pediatrician's meeting, I would say that you have to do a smear and look for the AFP. But then that has changed. The microscopy center still exists, but we have moved forward, much forward from that. We have a large number of tests now available, including chest X-ray, Gene Expert, TrueNat, and the MGIT. So briefly discussing some of these tests, chest X-ray has made a big comeback. So whether you take the adult algorithm or the pediatric algorithm, chest X-ray has the prime place of importance. I'm a big fan of the new IAP guideline that Professor Virendra Singh and the team has written, which is a very good document. In fact, has a lot of pictures of X-rays also. So, in adults, what I found of late is that with better and better tests being available, the physicians are losing skills of picking up TB on X-rays, which is a very important skill. There was a time 25, 30 years back when you went for a 3-month training to the National Institute, and you had to sit through every day looking at X-ray after X-ray to learn how to read X-rays. Of late, we immediately rushed to a CT scan. Last week, I had a patient in the medical college where because the pulmonologist rushed to a CT scan, the diagnosis became interstitial lung disease and the diagnosis of TB was missed. So, reading X-rays is a very, but I don't think that this August audience needs to be told on X-rays, but that guideline document is very good and it actually describes X-rays very well for reading. And the thing is that the government of Kerala has gone one step forward and has made X-rays also free of cost to patients. In places where chest X-rays are not readily available in the government, the patient can in fact, outsource. The X-ray facilities can be outsourced and the X-ray can be taken in a private lab and the government would actually reimburse for that. That is the way we go. But of course, the main tool today remains the nucleic acid amplification test. So we have two tests, the cartridge-based nucleic acid amplification test, GeneXpert, and the chip-based nucleic acid amplification test, which is TrueNAT. TrueNAT is an indigenous machine which is available in India. GeneXpert, of course, is an American machine, which obviously the patent is running out. We hope that the cost will come down. And GeneXpert has also come out with a new machine called the Ultra. The machine is same, but the cartridge is called Ultra, which has much higher sensitivity. So these are the two key tests today for the diagnosis of TB. Having said that, the sensitivity and specificity of GeneXpert remains extremely high. Pulmonary TB, pulmonary smear negative TB in adults, the sensitivity suddenly drops to somewhere around 50%. So, the sensitivity is very high for smear positive TB. Am I audible?
In between, not audible.
Am I audible now?
Yeah, now audible.
Okay, sorry. I think some connectivity issue just popped up. So I was saying that in smear positive TB, the sensitivity is 99%, whereas in smear negative culture positive TB, the sensitivity comes down to around 50%. So the test is very good in smear positive where you don't really need the test. The smear itself can pick up the diagnosis, but the sensitivity and specificity for rifampicin resistance is extremely high at 95% and 98%. So it has two purposes. One is TB diagnosis and the other is rifampicin resistance diagnosis. When we look at extrapulmonary TB, the studies, the meta-analysis have all been done comparing many of them comparing GeneXpert with culture positive specimens. So when you compare with culture positive specimens, the sensitivity remains very high, even though it's not that high in pleural TB at only or less than 50%. But the real comparison should not be with culture. The real comparison should be with the composite reference standard, because in CSF, not all cultures are positive. So in a TB meningitis, the meta-analysis says that the sensitivity with the composite diagnosis, when you take all the diagnostic parameters, comes down to around 55%. But this is even lower in clinical practice. So if you look at the neurologist who does maximum TBM cases in Kerala, he would tell you that it's almost 10% in this experience. So, the test doesn't really perform well in extrapulmonary TB. In fact, for gastric lavage and aspirate, which is applicable to children, they have compared only with culture in the WHO meta-analysis. So, the composite reference standard really didn't come. So that is what I liked in the new IAP guideline, 2020 guideline, where Professor Virendra Singh and team have very clearly written on these things, that even though these new tests are very good, they warn you that the sensitivity is much lower than culture. And they also say that culture is positive in childhood TB only in about 30 to 50% of cases. So, the new test would be positive even in lesser number of cases. So what they say is, as a routine test, if the test is positive, the chances of the child having TB are very high. But if the test is negative, you still have to consider whether it may still be TB. If you are really suspecting TB in the child, maybe repeat the NAT, maybe do some other test, maybe look for a culture, which of course is available in certain places. So that is something that they really brought out well in that document. The other new test which we talk about a lot is line probe assay, but this is not a test for diagnosis. This applies only in smear positive specimens. So 50% of my patients, the adult patients, are smear positive. So, I can send a sample to the lab and the direct line probe assay can be done, and I can get the results of INH resistance, rifampicin resistance, and many other resistance within 3 days with a line probe assay. That is the advantage of this test, that I get resistance to multiple drugs out of this test. But your cases, the pediatric cases, are going to be smear negative. Many of them are going to be culture negative as well. So when the smear is negative, the microbiologist does a culture, and the culture isolate after 2 months goes to a line probe assay. So the moment the smear is negative, there's a delay of 2 months in a line probe assay. But if the culture is also negative, a line probe assay is not possible. So, this is a good test, but it may not really be applicable to children. Skip this. The other good test is a liquid culture, which would be very useful in children. The MGIT 960 machine is available, 3 places in Kerala, which of course should be considered if you have a very difficult sample. Like if you have a suspected tuberculoma and you're doing a brain surgery, don't go. I mean, Gene Expert is a good test, but don't limit yourself to Gene Expert. You're not likely to get one more sample later. So such precious samples, definitely send the patient's sample to a MGIT wherever available. So if you look at the adult algorithm, for a suspected case of TB, you do an X-ray and a smear together, smear and X-ray together. If the smear is positive, you're diagnosed TB, but still to diagnose resistance, you will do a NAT. So all our patients, the smear negative, X-ray vision sagacity of TB would also get a NAT. Certain special groups, including children, pregnant women, HIV patients and all, directly go to a NAT without even doing a smear from a long time. And today you have something called upfront NAT, that even in adults, certain tuberculosis units in Kerala, you don't do a smear, you're directly going to NAT, and DTO Thrissur is actually offering that to many patients in Thrissur. So, smear, which is what Robert Koch is known for, is definitely on its way down. And every patient who's diagnosed as TB in India today has a right to know the rifampicin resistant status and other resistant status, which is called universal DST. Now, coming to the diagnostic algorithm in children from the 2020 IAP RSP guidelines, now here the algorithm starts with the chest X-ray. There's no smear anywhere there. So, I mean, in adult, we would have gone with a smear and X-ray at this point, but here we go with the X-ray, and then it goes more or less similar. So, if the X-ray is suggestive of TB, you go with the NAT. If the NAT is positive, is microbiologically confirmed, you look for resistance. If the NAT is negative, then you will look for, other ways of diagnosing TB. Do you have a lymph node? Can we repeat the NAT? Do we need a higher opinion? So that is how it goes. On non-specific shadows after a course of antibiotics, the shadows persist, then again it goes back to a gastric aspirate or a induced sputum or a expectorate sputum for NAT again. So, that is how it goes. Even a bronchoscopy can be done and sputum can be sent. The chest X-ray is normal evaluate because all the symptoms of TB like cough or fever more than 2 weeks, weight loss, everything is there. So the child should be evaluated for extrapulmonary TB and referred to a higher center. This is an algorithm which was there just prior to this. And if you look at it, this started with a chest X-ray and a skin test for TB, a Manto test, which is now not there in the algorithm. So the current algorithm does not have that. So if you look anywhere, Manto or IGRA is not there in the diagnosis algorithm for diagnosis of TB disease in children. So where does the other test come in? So we were talking of latent TB infection. So for diagnosing and treating latent TB infection, you have to diagnose latent TB infection. That is done by a set of tests called the tuberculin test, the IGRAs, and the CTB. Now, CTB is a very good test which has come, but the validation study was to be taken up. COVID put a stop to that. So the validation is not done. So what is available is a IGRA. Tuberculin, I tell you, has not been available. Standardized tuberculin has not been available in India for the last 15-20 years. So if you send a child for a tuberculin test, you will get it done only by a non-standardized tuberculin, which will give you highly erratic results. So tuberculin is something you cannot consider. And for it's very clear from all guidelines all over the world that these tests cannot diagnose disease. They can only diagnose infection. There's a huge difference between infection and disease, and you cannot even rule out disease if the test is negative. So the role is mainly for the diagnosis and treatment of latent TB infection. And IAP has come out with strong guidelines on when and where to test the child. So the availability of the test is there, as the DTO told you. But if clinicians start sending cases outside of the diagnostic algorithm and outside of the suspect criteria, it's a costly test, and we will not have enough kits available to test for all those children and adults. So you have to be very judicious in whom you refer for such tests. The new IAP guideline very clearly talks on extrapulmonary TB. I mean, every system, TB meningitis, lymph node TB, everything has been covered very well. I should also tell you that the Indian extrapulmonary TB guidelines are available on the TBC India website, tbcindia.nic.in. And this is done by the All India Institute with experts from all over India, including Kerala. So this is a good document to download in addition to your IAP. So I'll rush through treatment now because I'm running out of time. So what you have now new in treatment is the daily regime came in 2016, and the new drugs called bedaquiline and delaminid, which is very costly drug. Bedaquiline is about 18 lakh rupees for a course in the international market, is available free of cost to your patients. Delaminid, a Japanese drug, about 1.5 lakhs in the international market, is available free of cost to your patients. So these two drugs are available, and large number of patients in India today are getting those drugs. With adults, you have a daily regime today, which is a 8-week intensive phase followed by a 16-week continuation phase. And in adults also, since 2016, we have moved to weight-based fixed dose combinations. And the dosages are very different from 2016 when you compare to the earlier doses that we were working with. If you look at the highest weight band, adult would actually be getting 900 milligram of rifampicin and 450 of INH and 2,400 of pyrazinamide, whereas the lowest weight band would be getting a dosage which is even lower than the dosage you might give to a child. So it's all a bit complicated now, and with a child, you have to evaluate for drug resistance before you start treatment. So if you do a NAT and the rifampicin resistant status is known, you can go for a DSTB drug sensitive TB treatment or a drug resistant TB treatment if you have a rifampicin resistance detected. However, if you don't have that initially, and then you have to look at the contact, if you can, not every child you'll be able to find out who's the index case. But once you have an index case, based on the index case, is the index case a drug resistant TB, then this becomes a probable drug resistant TB, and the treatment is for drug resistant TB. If the status is not known for the index case, then there are other ways of doing it. For the child also, the regime is the same as we discussed for adults. So it's a 2 month of 4 drugs and 4 months of 3 drugs, HRE, HRZE in the intensive phase. And again, fixed dose combinations are used. The difference between adult and children fixed dose combinations is that it is dispersible tablet for children, whereas the ethambutol comes separately. And again, there are various weight bands, 1, 2, 3, 4, 5, 6 weight bands, on which towards the end, the dosage required is so high that you start using adult fixed dose combinations as well. It's a bit complicated. I mean, I don't try to memorize this. I keep these ready reference documents with me. So every time a patient comes with a various weight band, I often check. So if the child is more than a particular weight band, adult formulations are required. And if an adult is below a certain weight band, the pediatric formulations are required. So it's not that these are used pattern. Today, the treatment that I give to adults, I am the nodal officer for MDR-TV in Kerala. So I treat based on resistance pattern. So it's a DST based treatment. Again, I'm sorry, my network is not very stable. I hope that I'm audible. WHO has reclassified the drugs into A, B, C. And at the top of the list today, you have bedaquiline in addition to linezolid and levofloxacin. And any regime has to have all those 3 group A drugs. WHO actually talks of 4 drugs in the intensive phase and 3 in the continuation phase. So bedaquiline is given only for 6 months. So your continuation phase will not have bedaquiline. But the government of India, the RNTCP or the NTP decided that linezolid is going to cause a lot of adverse events. So we actually went with a 5th drug in our regime. So our regime has about 5 drugs in the intensive phase and 4 in the continuation phase where bedaquiline is stopped. And linezolid dosage actually drops in the continuation phase. So these are the regimes for adults. There is a regime for INH monoresistance. There is a shorter MDR regime, and there is a all or a longer regime. The thing to remember here is that injectables have been taken out by WHO from the regime. So only amikacin is there in the regime. So kanamycin is no longer recommended. But since the regime is going on in India, for the time being, we are continuing with it. I skip this. When it comes to childhood MDR-TB also, the regimes are more or less similar. The only thing is that bedaquiline cannot be used in children less than 17 years now. WHO has actually allowed for bedaquiline use for children above 6 years, but the Drug Control General of India, DCGI, has not given approval so far. So once the approval comes, we would be using bedaquiline for children as well. It's a very good drug. But as of now, delaminate would be used for children below 17 years of age. So you have that all-oral longer regime for milder forms of TB, and you have the injectable containing regime for more severe forms of TB. When it comes to MDR-TB, it is decided by a committee. There's collective responsibility. So obviously, such cases would be coming to us. So I'm not going into details for it. The most important thing which is coming into is management of latent TB infection. Like we discussed earlier, you can prevent TB in children, and you are not going to achieve those milestones. The clock might be ticking. The clock will keep ticking unless we start addressing latent TB and we look for a vaccine. So those are 2 important things which need to be done. And the Honorable Governor and the Health Minister of Kerala with the Indian Association of Pediatrics came forward with the National Program Manager and WHO representatives coming in to inaugurate this on November 1st for children. But it's a bit slow in being taken up. The DTO was talking about numbers which are very small. I mean, the numbers definitely would be much more than that. So the major group that is screened is contacts of microbiologically confirmed pulmonary TB cases. And of course, HIV patients and children less than 5 years anyway were covered earlier. So the policy is to test and treat in those above 5 years of age. Below 5 years and in HIV infected children, you don't have to test. You can just treat without testing. The test being used is IGRA, which is quantiferon gold in tube, and the regime is 3 months of INH and rifampicin. However, HIV infected people would continue to receive the 6 months of INH regime. So actually, there are two different regimes going on together. So this is in brief about that. This is being done for adults as well, but obviously it is still not launched, and it's an extensive algorithm is there. Time doesn't permit me to go in on that. Vaccine is something that we need badly. BCG is the only vaccine we've been having for 100 years, like the AFP microscopy. But even though there are a lot of promising vaccines, some of them didn't come up. If you look at some of these vaccines being developed along with, Serum Institute of India, with the experience in the COVID vaccine being pushed through, we do hope that a TB vaccine would also be pushed through, and we will be having a vaccine very soon. What I was telling you earlier is that kanamycin and injectables are on its way out. So soon we may get an all-oral shorter regime. So if bedaquiline is endorsed in children by DCGI, then probably you will have a non-injectable containing bedaquiline containing regime for children very soon. It's a new regime called the BPAL regime, which is very successful in difficult cases, which is a short 6-month regime for MDR-TB, which is going to be tried in a research mode in India. It's not going to be rolled out as such. So that is also going to come. So sorry that it took about 4 minutes more. The strategy for TB control, which is now TB elimination, has changed. So you have a TB elimination, Kerala TB elimination plan. Large number of new tests are widely available. The DTO Thrissur has at her disposal a large number of gene expert machines and TrueNat machines, which she is placing in peripheral institutions as well. And she is also offering you IGRA for those cases who are eligible for IGRA as per the guidelines. Newer regimes are available, new drugs are available. I hope that DCGI will give approval to bedaquiline because it's a very good drug, extremely useful, a drug which is costly, also given free of cost to our patients. So it's just a question of approval from DCGI. And many more changes are also coming, eagerly hoping for a new vaccine as well. If those things come in, we'll be able to do even much more good for our TB patients, as well as those who are going to develop TB in the future. A large number of documents are there. I would recommend that if you have time, you could go to the WHO website, and there are WHO consolidated guidelines, module 1 to 4 from 2020-21, which are downloadable. The MDR-TB guidelines we are working on is a 2019 guideline. 2021 guideline should come next month. So, that has a pediatric MDR-TB section separated. Professor Virendra Singh was actually working on that. So, a lot of new changes, training, MO training modules also from 2020. So all these documents are available online. You can easily download. Thank you. I think questions are being taken at the end, but if the chair permits, probably any burning questions can be put. Thank you so much.
Thank you, sir. Thank you, sir, for excellent presentation, sir. So please stay with us. We shall have a discussion after the end of second session, sir.
Okay.
And so for the second topic, we have our Ananda Kesavan sir is here. And for Ananda Kesavan sir, requires no introduction. And he is the additional professor of pediatrics from Government Medical College, Thrissur, and is the author of IAP textbook of pediatric radiology. So you'd be the ideal person to talk about chest X-rays in tuberculosis. So over to you, sir.
So, very good evening. Thank you for that excellent talk by Dr. Sanjeev Nair, sir, and he also decreased my burden because he explained almost everything. Next 20 minutes I speak about something about the utility of X-ray in tuberculosis diagnosis in children.
Sir, your video is not visible, sir. Your video, sir.
Huh?
Sir, your video is not visible. Video how to come? Can see my screen? The slides are visible, sir. Slides are visible. Sir.
Okay, then you go ahead.
Okay.
Oh, okay. I think there was some problem. So, because very important, as Sanjeev sir rightly mentioned, the first tool is X-ray. Because primary child TB is possible, so microbial diagnosis may be difficult. And also progressive primary TB like cavity lesion is very rare in children. So AFP again maybe a problem here. And difficult to get the gastric acid to make a tissue diagnosis. All these are some problem with the pediatric TB diagnosis. So chest X-ray is very important, but there are some problem with chest X-ray because there may be some personal variation. What one person's interpretation may be different, and the quality of film also very important. So many technical error can happen, and the artifact, timers, normal variation. So many problems are there with this one. So maybe a difficult. So errors in data of interpretation can lead to both the underdiagnosis and overdiagnosis. So here you can see the diagnosing chest X-ray alone, you may overdiagnose because there will be around 20-30% chance for overdiagnosed X-ray. And if you are the specificity of X-ray also very less in compared to AFP microscopy. It is 50% with the chest X-ray, but you can see that 98% with the AFP microscopy. And before reading any X-ray, not only this TB X-ray, you have to keep in mind certain technical aspects, penetration, rotation, inspiration, motion. So what is very difficult to keep in a child because of the child may be crying in a dark room when parents are away. You can see here it's underexposed film. You can see here. So how can you detect the hyena infant here? You cannot detect the hyena node here. Here you can see my overexposure may be a problem. Underexposure means perfect exposure is important. So when it is a proper exposure, you can see infant here. But when it is overexposure, you cannot see it here. That is the problem. So exposure is very, very important. The proper exposure is very, very important. Again, rotation is another problem. You may think it may be pneumonia or some other paratracheal lymph node, something like that. That it is a thymus. So rotation, inspiration or expiration view, and a proper exposure, everything is counted before interpreting. So a high chance for the missing out or overdiagnosis of X-ray TB is very there. So then, as already mentioned, test is very important primary diagnosis test in a child of more than 2 weeks fever, more than 2 weeks of cough, and the 5% reduction of weight in 3 months. You have to think about it. So when you are seeing X-ray, you have to ask a certain question: whether it is normal or abnormal. If it is abnormal, then it is suggestive of TB. If it is abnormal, if it is non-TB, then TB, what is it? Then these are the questions you have to ask. So you can see here, chest X-ray, you can see that it is abnormal here. But here, what you can see, it may not be suggestive of TB because you can see a foreign body here. So you can see the collapse, Silhouette sign is positive. So it may be metallic foreign body. So it is suggestive of, it is not, the collapse is suggestive, maybe tuberculosis. But since there is a foreign body, it may not be a tuberculosis. So proper exposure, as we already mentioned, so very important. Here, this foreign body is not visible. You can see the foreign body. So proper positioning, exposure, pace of respiration, rotation, everything is very, very important. Then before you are commenting next, especially when you are commenting on a lymph node, it is very important. So relative mix is a gone focus, as we already said that the gone focus is the primary instinct which we are seeing. So gone focus for the many fact. So primary gone focus may progress and it may lead to progressive primary disease. Whereas it may be contained either by treatment or by natural heal, and later it may go for a reactivation also. So all these things you have to keep in mind when you are reading a chest X-ray. So what are the outcome of this gone focus? So a real lymph node may involve the airway, it may intra or extra luminal compression, it may lead to bronchopneumonia consolidation, or it may lead to rupture in the pleural effusion, pedicular effusion, biliary effusion, and also sometimes it may include cavitation with the intrabronchial spread also. So may lead to progressive primary tuberculosis. So all these findings you can expect in X-ray also. So for example, it may be a consolidation, may be miliary tuberculosis, it may be obstructive emphysema, or it may be atelectasis, may get a bronchiectasis, or you may get a primary coma, just we are seeing. It may turn to a pleural effusion, and it may rupture into bronchus, and it may lead to bronchopneumonia, and also lead to miliary tuberculosis. These are some of the outcome of our tuberculosis. So all this type of X-ray, even though it is not very common in children, but you are expect in a pediatric age. So what are the, according to NTP, what are highly suggestive findings? One is hilar or mediastinal lymphadenopathy, chronic cavity lesion, and a miliary period. These are the three important findings suggested by NTP for diagnosis of tuberculosis. But you may get a consolidation, non-homogeneous opacity, then you get some other kind of shadow also. But with the help of other evidence, you are diagnosed tuberculosis. Here, I think it is already shown by Sanjeev sir. So you can see the paratracheal lymph node, you can see that right hilar and paratracheal lymph. So it means very important of primary TB. Now here you can see sometimes the lymph node may compress. So here you can see subcutaneous lymph node. Here some mass like that. He narrow, left bronchus is very narrow. So that may give evidence of a lymph node, even though it is not clearly visible here. But sometimes you can use a so you can narrow, we can see some mass here and a narrow side of the bronchus, and there is corresponding you will get some consolidation in that part. Here again, it is another type of expansion pneumonia. Again, you can see massive pneumonia, secondary lymph node compression. You can see lymph node here, and the entire part is. So it may present as a pneumonia. Usually, we get a pneumonia not responding to conventional antibiotics. Our child, since the tuberculosis which is not there, and you can see diffuse hilar node, very much suggestive of tuberculosis. So these are the three important findings I want to mention. Either lymph node, trachea, so you may get hilar lymph node, paratracheal lymph node, you may get subcutaneous lymph node. These are three important forms of lymph node. You get it. Then you get a miliary tuberculosis. Then you may get a fibrocavity lesion. Now these are the three important findings. But as you know, these are the X-ray findings. Large lymph node, hilar, paratracheal, subcutaneous. But there are so many conditions you will get. So there are so many causes of false interpretation because you may get hilar and paratracheal share due to so many reasons. And pneumonia, bronchopneumonia, especially not responding to antibiotic, maybe due to tuberculosis. Unilateral pleural effusion. Pediatric you have plenty of reason for pleural effusion. So you have to roll out all these lesions when you are considering tuberculosis. Cavitation unusual, of course, collapse also not very common in children. And immediately mottling also you have to keep in mind it. So you have to suspect pneumonia when it is not responding to proper antibiotic. So in addition to three important findings, one is the hilar, parahilar, lymph node, second is mildew mottling, and cavity. Cavity and mildew mottling is not very common, so we have to depend upon hilar, paratracheal, and subcutaneous lymph node. Here I can see the lymph node with the bronchopneumonia, mosaics, large paratracheal and hilar lymph node. And you can see also mediastinal lymph node, you can see here. And the hilar problem is there. That I want to mention that because there are so many mistakes may happen because when the sarcoidosis is not very common, but infection like mycoplasma, histoplasma, even viral adenovirus may produce hilar lymph node. Malignancy, especially Hodgkin lymphoma, no-Hodgkin lymphoma, leukemia also may give some shadow of hilar problems. Interstitial lung disease, again, may lead to, and the heart failure, you can see the hilar problems. And again, it is another example lymph node with the pneumonia. And it's one of our child from Rinyalakuda, Krishna Tolia, otherwise she was healthy, fever of 2 weeks, cough of 7 days, breathlessness. She admitted this picture here. So here you can see it is a consolidation like normal pneumonia, but it's irregular and it is non-homogeneous. So child was not responding to antibiotic, treated with the antibiotic, and it's not responding to antibiotic, then it is increasing size also. That is important. So here pneumonia, not responding to antibiotic, then we have a sputum positive, 3+ positive sputum sample. So these are only very few cases we got sputum positive during last few years. It's one of the cases we got sputum positivity here. And a child gradually is improved. So in case of pneumonia not responding to conventional antibiotic, you have to think about when you are using antibiotic, don't use spectrum with anti-tubercular spectrum antibiotic like ofloxacin or levofloxacin or quinoline or even amikacin, such antibiotics for treating this pneumonia. And it is another common process in pediatric age of queer effusion, you can see here. Here also the queer effusion, but in addition to here the mediation shift is not so prominent, so it may be pneumonic effusion rather than pure pneumonia, pure pleural effusion. I am not going into details about pleural effusion exercise. We may get the uniform homogeneous opacity, obliteration of claustrophrenic angle, mediation shift, and Ellis curve length. And very rarely one get it like that, but you rarely make it pericardial effusion also. If it's a rupture and it is a spread to adjacent area, then you may get a pericardial effusion also. It is cavity pneumonia, left upper lobe, and here you can see also reactive streptococcus, multiple cavitation area. You can see that all this is indicating that either regular streptococcus or regular treatment. This another child is a 6-year-old male with recurrent fever, loss of weight. You can see a very large shadow on one side. Even we are suspect something, some tumor-like mass. But when you add in a lateral X-ray, which is a collection of fluid in the fissure, so very simple. Here we have to stress the importance of lateral X-ray. So a mass like appears to be like here. You can see the simple collection of fluid and later proved to be pleural effusion due to tuberculosis and a promptly respond to anti-cox treatment. So lateral X-ray picks up 12 to 9% of cases. So I think sometimes we have to get a lateral X-ray also. Here also you can see that here some mass and something like that here retrocardiac, but here you can see clear cut pneumonia or patchy consolidation here suggestive of tuberculosis. So lateral X-ray sometimes it is a very important, especially in the retrocardiac opacity, subcranial lymph node, behind the diaphragm. So in all these cases, but we are not utilizing lateral X-ray very promptly. Here you can see lateral, you can see some kinal lymph node, but here it is very clear. It is a donut sign. You can see here. What is it? So the donut sign is indicating that usually you get one of the pulmonary artery and the aorta. The donut sign, the subcranial lymph node also complete the ring. That is the donut sign. You can see the complete ring is formed by the U-shaped. The lower portion is completed by lymph node. That is donut sign. So anterior superior part is a normal LP or RPA. Inferior part is a hilar and subcranial lymph node. That is and the central radius media is covered with the trachea and the bronchi. That is why you are getting this donut sign here. And it's immediate TV also. Okay, what we are seeing nowadays, 3-4 cases during last few months. You may get a medium or to solve a reason. So it is not very common. Then also bronchopneumonia, viral pneumonia, bacterial pneumonia, pulmonary edema, and interstitial lung disease, tropical eosinophilic, pulmonary infection, aspiration pneumonia, pneumoconius. So all this you may get a miliary shadow. But when you are interrupting miliary shadow, you should be very careful. So it's not always like that. A miliary tuberculosis always. Miliary shadow is always due to miliary tuberculosis. We got another child from Palakkad, severe waste, and you can see the bilateral patchy opacity and data improvement. Then we could detect AFB also here and gradually improvement. So miliary TB are also not very uncommon children. So another child from 12-year-old from Pattambi, he had fever of 3 weeks duration. Very healthy, 46 kg. And no family history of tuberculosis. Cellularly active, no history of all routine injection were normal. At that time, it's an old case, Mana test also negative, no family history of tuberculosis. But the patient is referred as like a pediatric because of the bilateral shadow, miliary shadow. So how to confirm this because child has no family history of tuberculosis, gastric aspect negative, X-ray is highly suggestive, and we cannot no other further test to prove. So one more exam shall confirm a diagnosis, luckily, because fundus test showed multiple coronary tuberculosis. So it is a case of miliary tuberculosis, but the gastric aspirate and Mana test was negative. Child was very good, healthy also in the aspect weight is around 46 kg. Another child, you can see one of the child I have seen recently about the trials and positive. You can see here very clear cut history of conducted TB, fever, 2 month duration, and you can see massive irregular patchy consolidation, and which is on the bronchitis changes also. So it is a case of a bronchitis, and it is with the collapse consolidation also on right side. So such extensive progressive pulmonary tuberculosis we can see in children also. This is another child with a history of AKT for 9 months, and he had not improved much because after 1 month also, X-ray also almost same findings. If fever and cough persisting, that is why we are taking a CT scan showed bronchitis changes. So here bronchitis changes. That is why we referred the child to surgery department. He underwent the surgery. He is symptomatically better, completely cured. So sometimes in addition to all this treatment, you have to do vigorous physiotherapy, good nutrition. And just also we have to stress out these things. Surgical treatment is also very, very important. So these are some and sometimes during treatment, we already see that the child is not improving. That may be due to bronchitis. Sometimes there may be deterioration during treatment. So you can see here child is a mild shadow, then it is increased, then it is severe. So very rarely, especially during tuberculosis, immune reconstruction inflammatory syndrome also you have to think when the child is not improving or deteriorating. And if you are strongly suspicious 2B cases, then you have to think about immune reconstruction inflammatory syndrome, and it may happen after 2 months, 3 months like that. Just not like that; it will happen immediately after treatment. Now I will come. I think I discuss some X-rays which is suggestive tuberculosis. Some confusing X-ray. It's a 4-year-old child with recurrent pneumonia, recurrent respiratory infection, father suffering from TB. Here dyspneic, cyanosis, clubbing was present, a chest X-ray showing bilateral shadow, interstitial lung shadow. So it is cyanosis, clubbing, and the father suffering from tuberculosis. You can see this one violet shadow, and later also you can see the another type of shadow. So actually, the father died of tuberculosis, and later put here HIV. This child also had HIV bilateral. So it is a first one was pneumocystis pneumonia. It may be a lymphocytic interstitial pneumonia. So it's another case, similar case with Farhana 6 year. It's an old X-ray. When we hear so many cases of HIV patient, we used to see such a shadow. It's not a malignant shadow. So that is why we are stressing in any case of tuberculosis, we have to test for HIV. That is a very, very important, and that is mandatory also. And another thing what is you can make it interstitial lung is immediate shadow. You make it shadow like that. So that is also mimicking miliary tuberculosis. Yeah, it's sarcoidosis bilateral, large lymph node, timid tracheal, hilar or parahilar lymph node. So it will be sarcoidosis may mimic the hilar lymph node. So here you can see fever of 1 month duration, weight loss. It may mimic the type of lymph node, but it's not. If you are looking at it very carefully, then you can say it is not a lymph node. It is a paraspinal collection. So it is a port spine only. So very rarely we get such a findings. So it may be mistaken for the hilar lymph node, but actually, so importance of a lateral X-ray again and again stressing is a port spine. It is after 1 year history of recurrent respiratory infection. Child was unimmunized. Father family history of tuberculosis there. On X-ray he got severe wasting, peeing grade 4, emaciated child. A child got respiratory distress also. This is X-ray which is showing a diffuse bilateral shadow, which prompted them to for diagnosis of tuberculosis because failed to thrive. Child got a severe protein energy malnutrition. Family history of tuberculosis is there. Child got a bilateral crepitation, all these findings. That is why suspected tuberculosis. So later we found that MRI showing it is a case of diaphragmatic hernia. So diaphragmatic hernia, diffuse bilateral diaphragmatic hernia, sometimes it may present a very late age also. This is a 4-year-old with fever and cough, 14 days duration, history of fever and cough 1 month back, and active, not dyspneic, and crepitation light also. So here you can some cavity-like lesion here. So we thought it may be tuberculosis also. There is some distant contact with tuberculosis also. So some cavity-like in here, so large cavity-like lesion something. So that is why we are taken a dengue abscess tuberculosis. Then we are taken a barium meal. So it was a just not a cavity. It is a morgagini hernia. So it is large cavity-like lesion which is appeared here. But if you are looking at it closely, you can see horstration here. Intestinal lumen, you can see horstration here. So it is a case of morgagini hernia. So many years, she evaluated for recurrent respiratory infection, and all test routine test was normal. Chest X-ray showed some large lymph node like lesion here. So otherwise healthy, but a recurrent cough. Mano test was negative. Like the old exercise, so mano test was that time it was negative. Then you can see the shadow here. Then finally it is a well defined shadow here, and it is for child under surgery. There's a bronchial cyst. Drawing drawn by pediatric surgeon. So many shadows may mimic hylar lymph node, pneumonia mimicking condition. So you have to be very careful. So overdiagnosis, underdiagnosis to focus is very common. If fever and sweating, pneumonia not responding to antibiotics, there was some shadow, solid shadow here, and the latex also same shadow. That's we prompt to take an X-ray. Then just ganglion neuroblastoma. The persistent shadow, when it is not responding to antibiotic, so of course tuberculosis is a possibility. But when you have to take some other history, so many of these cases may be at overdiagnostic tuberculosis. Here it is a 2-year poor weight gain, distant cyanosis, and here bilateral shadow, some idea. So it is a case of TAPVC. Actually, it is a not paratracheal shadow. It is a esophagus vein. It is a abdominal vein. You can see the both sides. So it is a case of TAPVC, total and supracardiac type of TAPVC, and a child underwent surgery and improved. So it is just exactly look like a paratracheal lymph node. A former node boy from Palgat, noisy breathing. So we thought it is a just a laryngeal Malaysia, but we reassured the patient, but the patients are very curious and anxious. So we have taken X-ray showing bilateral shadow here, and then later and again repeat the X-ray 9 months. It showed only thymus only. So such a large thymus with a stridor, we may suspect it may be some lymph node compressing the trachea. So it may lead to fast impression of tuberculosis. So to sum up, reading of radiograph is important skill, and it is an important tool in the diagnosis of the pulmonary tuberculosis in children. So whenever I get an issue of a prolonged cough, prolonged fever, with weight loss, so you have to opt for the X-ray. Remember, the TB suggestive, and all the shadow may not be. So you may overdiagnose or underdiagnose, but carefully history is very important. History of contact, physical examination, and other tests already mentioned by Dr. Sanjeev Nair. And then with everything we have to worry about, and then you will get a proper diagnosis. Alternative miliary and chronic fibrocartilage are considered TB suggestive. Finally, we already discussed one. Systematic and over and underrated. We already see so many case scenarios. Remember impact of rotation, pace of respiration, exposure, motion, artifact effect. So whenever you are interpreting a chest X-ray, not only TB chest X-ray, but any chest X-ray, all the technical aspects should be very as far as possible to be maintained. Otherwise, you may get a fast impression. And then lateral review also. So thank you for the patient hearing. Any questions?
Thank you, sir, for the excellent talk. And actually, we have one question for only few questions come in the chat box. So first question for Dr. Sanjeev, sir. What is the cost of IGRA test and what is the turnaround time? And what is the advantage of IGRA over CB NASH? That is the question came.
Yeah, I think it's a good question. Two questions related to IGRA. I think I'll take them together. IGRA, basically the major issue with IGRA, when we chose IGRA for the LTBI as a test, is the cost. It will cost around 1,500 to 2,000 rupees. Of course, negotiated cost for the kit and everything for a research study or for programmatic conditions still would cost the government around 1,000 rupees. 700 plus 2,000 rupees per test. So that is a very major issue. It takes a bit of time for the test results to come in. The other disadvantage is that you need to process the blood. It's a blood test, so you have to process the blood very fast. If we keep the blood pending, the results would actually be, if you can't process the blood fast, if you collect in a very peripheral center and then transport the blood after next day or something, then the results would be altered. So Those are the major disadvantages also. But the advantage over the comparison of IGRA should always be with MANTO. The comparison is never with CBNAT. CBNAT is a totally different kind of test. CBNAT is a test for TB disease. So if we do CBNAT, we are trying to diagnose TB disease, whereas IGRA is a test for IGRA and MANTO are tests for TB infection. So I expect that if IGRA or MANTO is done for me, it has to be positive because I have interacted with so many patients. But if a CBNAT is positive for me, then I immediately have to rush for treatment and I have disease and I have an infectious patient. So that's a totally different thing. So we don't compare IGRA with CBNAT at all. The comparison is always between IGRA and MANTO. The advantage of MANTO over IGRA is that it is cheaper, but the disadvantage obviously is that standardized tuberculosis is not available. Solution is not available in India today. The other disadvantage of MANTO is that you need, I mean, it's a lot of performer specific. So if the MANTO is not done properly, I mean, the injection is not given properly, the reading is not done properly, there are so many errors which can happen. And the child or patient has to come on second occasion for reading after 48 to 72 hours. In field conditions, about 70% only come. I mean, remaining 30% do not come back for the reading. So, you have a lot of this data. On the other hand, IGRA, you need to take blood only once and then the result is available. The other advantage is that in a country like India, where a lot of BCG immunization is done, IGRA does not, I mean, the results of IGRA are not really affected by BCG, whereas when you do a tuberculosis test, the results can be affected by BCG. So that is a comparison. Please don't, I mean, that was the effort I was trying to make in the talk also. Smear, X-ray, gene expert, liquid culture, and all are tests for disease. They are not to be compared with IGRA and MANTO, which are tests for infection. They are totally different things which we do the test for.
Okay, thanks, sir. One more question. What's the role of streptomycin in CNS tuberculosis? Actually, the new oral treatment is enough for CNS tuberculosis.
Yeah, I think this was a debate which happened with the WHO 2005 or so guideline. At that time, there was a lot of debate on whether you need streptomycin or not. IAP also came forward in earlier guidelines saying that, probably TBM can be treated without streptomycin. The current guidelines, at least for adults, is very clear that you don't give streptomycin for meningitis as we used to do earlier. You just give a 4-drug regime. The continuation phase is increased to about 9 months or 10 months to have a total regime of almost a year. So you can give 9 months to 1 year of total regime. The continuation phase is long, but you don't really need to add streptomycin to the regime. And there is no retreatment regime with streptomycin also. So sooner or later, we are going to have a shortage of streptomycin as well. I think Ananda sir can also answer on that.
We had one case of TBM. The response to the oral drug was not very satisfactory. Later, we got permission from RNDCP. At that time, it is RNDCP. Then we put the child on streptomycin. Then that time, child improved. So I think we can decide whether that is not improving. Then we can give streptomycin. The child
So
improved.
Purushottam sir.
Yeah, Purushottam sir also there.
So Purushottam sir, your comment, sir.
Unmute sir. Unmute sir.
I couldn't join Sanjeev's talk. I was outside. I a bit late to join. I agree with AK. We are comfortable with injections for the CNS tuberculosis. And we had a child now with CNS tuberculosis. One girl who had this thing, vasculitis. She was put on the immunomodulators, mycophenolate mofetil, and during that period, she developed multiple tuberculomas. And that was a dilemma whether how long we can stop the immunomodulators. We stopped for a while. We continued ATT, and then now she's on combined treatment with the MMF azathioprine, and ATT also. She has completed 1 year of ATT, and we repeated the MRI, and even now the MRI shows some lesions. So how long we can continue? And we discussed with Dr. Aipsar Trivandrum. He is continuing it for a varying periods after 1 year also. So now we have taken a decision to continue ATT beyond 1 year, and now almost 15 months. We are going to repeat the MRI again. She is otherwise asymptomatic, but the lesions are still small. It's decreasing, persisting. Anyway, all the neurological cases we treated so far with injections regime, and we'll see about the other.
Two things are there. One is we have to start steroid also. I think the sir maybe start steroid. Secondly, we have to roll out the drug resistant tuberculosis also.
We have Parvati madam here. So madam, in comments.
Muted, Anna madam.
Unmute, madam.
Yes. Can you hear me?
Yeah.
One question to Sanjeev. That is, what is the impact of COVID on TB elimination program in Kerala? Is it impact of COVID?
Madam, thank you for that question. In fact, we had a long discussion in the Kesavan sir was there. We had a CME on Sunday, full day CME, state level CME, and this was like a 1 hour discussion we had. It's a very important thing that you raised. Even DTO was mentioning that. So I think the major, it has really affected in a big way. So, all over the world, the speaker was Srinivas from Geneva. So he was also speaking on the fact the world over. So the major issue has been that, at least in India, I'll not go to the world thing. In India, certain states, the TB diagnosis come down to the extent of 70%. In Kerala, that fall was not that much, but in Kerala, we missed something like 1,000, 1,500 cases as compared to last year. So the government of Kerala and the state TB cell and everybody got together for a catch-up campaign. So that was also done. So some amount of catching up has happened. So now, if you look at the numbers are more or less similar to what was the diagnosis last year. But in between, particularly during those lockdown months, there was a huge decline from the diagnosis of the previous year. For the strategy the government of India has come out with is you have a bidirectional screening. So today, the strategy is that every COVID patient, every suspected COVID, every ILI patient should also have a gene expert done for TB, and every diagnosed TB case is also screened with for COVID. So, you don't want to miss, because if you have TB and COVID together, the mortality has been shown to significantly go up. So, people die also much. So all those things have taken place. One of the major, whether we say that in a good way or a bad way, the thing is the TB program got a lot of gene expert and CBNAT machines. And those were the machines which were actually used for the COVID testing. So, the COVID testing was supported a lot by the TB program. So now the challenge for the DTO and others is to get those machines back. All those machines have gone for COVID. Now we want to get the testing done for TB. So we want all those machines to come back for TB testing because COVID numbers are going down. So the TB program has supported the COVID program in a big way, and all our machines were used for COVID testing. So it's a catch-up happening. Right now we have come back, but all those missing cases we have to pick up. From a clinician's point of view, what I am seeing is that today when I diagnose a TB case as compared to last year, the cases are coming in a much advanced stage. And with the advanced disease, patient would have been symptomatic and infectious for a long time. So from a pediatrician's point of view also, I would assume that these people would have infected more children at home before they were actually diagnosed with TB and put on treatment. So you could actually see an increase in pediatric TB also maybe in the coming 1 or 2 years. So that is also possible.
Thank you. Thank you very much.
Dr. Murli CP is there? Murli CP, sir, for chest medicine.
Murli is there. Murli could probably talk more on COVID and TB.
Any other comments?
I also have this. Murli is the can't unmute. Let Murli talk. Murli can't unmute.
Unmute. Only you can unmute.
Yeah. Thank you. It was a nice presentation. Both of you presented it well. Thank you very much for the presentations. The COVID has an impact on the diagnosis and health-seeking behavior of the patients in general, not only for tuberculosis but for other chronic diseases as well. So that has affected the diagnosis at least for a few months in the lockdown period. But now the patients are coming, as Dr. Sanjeev said, the patients are coming with an advanced disease. I mean the pulmonary disease. So that may be the impact of something like a fear to test. Like if they go to hospital with a cough, they will be tested for COVID and they will get isolated. So such fear factor is also there. So that might have contributed to the delay in the diagnosis as well. So at present, I think the TB, detection rate is more or comparable to the pre-COVID era. That's what I feel. Agree with Dr. Sanjeev. Thank you.
Sanjay sir, any data about drug-resistant tuberculosis in children?
Both, sir. Sorry.
Drug-resistant tuberculosis in children.
Resistance. Drug resistance. So drug resistance in children generally is a phenomenon which occurs as when they have a contact with adult drug resistance. Acquired drug resistance in children is very rare. I think like we would have treated about 1,300 MDR-TB in our center in Trivandrum, which doesn't cover Thrissur, it goes all the way up to Ernakulam. And the children we treated, numbers are very low, less than 10 maybe. But we had some difficult cases. We had a child with mental retardation. We had one child with HIV and MDR who became XDR-TB later and developed further resistance. But that girl, she started at around 9 years with us, 9 years age with us, and she survived till about 17 years, taking various multiple treatment one after another. And after 8 years, she actually succumbed to the illness. So the numbers are very small. Recently, from the pediatrics department in Trivandrum, we had a newborn with MDR-TB. So that was a very difficult experience because the child also was, went in for respiratory failure, had to be ventilated and all that. It was very difficult for us to, with children, some of the very small children, the challenge is, with the dosages for MDR-TB. The very small dosages, very difficult to tailor. And some of the drugs like clofazimine are all come in a gel capsule, which is, you can't break it into smaller dosages. So, dosaging becomes very difficult. For the mentally retarded child, the challenge child, we had to actually get a mortar and pressor, and we had to actually, grind the tablets and put it into something else and make the child take the tablet. So, those are some of the challenges. But the numbers are very small. What is
the usual procedure, administrative level? When you are getting a drug-resistant tuberculosis, whether we can do it in the Trivandrum or we have to send it to Chennai?
Sir, no Chennai. We have 2 centers in Kerala, one at Trivandrum and one at Kozhikode. So Thrissur actually comes under the Kozhikode. From Thrissur north, the 7 districts are Kozhikode. Yeah, but in the beginning, when 2008, when we started, every patient had to be admitted before we started MDR-TB treatment. Then that stopped, it became decentralized treatment. So every district now has got a district PMDT committee. So Thrissur district has also got a district PMDT committee with a pulmonologist, pediatrician, and various specialists are there with the DTO heading the committee. So that committee can decide, and it can be ambulatory treatment. So your child can be sent to this committee. They may physically see or maybe look at the records based on your recommendation, and the treatment can be done at home itself. In the beginning, when we had bedaquiline and delaminate, because there were cardiac side effects was a big concern, those patients had to be admitted for 2 weeks. But later, even that has been decentralized because our experience has shown the side effects are not very common. So even a bedaquiline, child taking bedaquiline can come to the committee and actually take treatment on an OP basis, but they might need more frequent ECG monitoring and more frequent follow-up maybe. So admission is not at all necessary, and the child doesn't have to go to any center. It can be done at district level itself. And for INH resistant TB, it can be done at primary care center. It doesn't even have to go to district.
And my question is that where we can test it, resistance?
Testing, so testing, we have a hub and spoke model where the samples can be collected. So if your child comes to any pediatrician here, there is a collection mechanism. So it's a free courier service. I mean, the program pays for it. So the sample would be collected in a Falcon tube, which is a conical special tube is there. And that sample, based on if it is a gene expert in Thrissur, I mean the NAT today, gene expert and CBNAT and TrueNAT are available in multiple places. So it can be done locally in Thrissur itself. I mean, medical college, obviously we have 3 machines sitting in medical college. So it can be done in medical college. So 60 samples can be handled. District TB center has and other places also DTO has kept the sample. But if
multiple drugs.
Yeah, so if you need, if you need further testing, like you said, for a complicated case, then you will need liquid culture. Now, liquid culture is available, and LPA and liquid culture are available only in Trivandrum and in Kozhikode. Kozhikode has a LPA which has been endorsed now, but liquid culture is there in Trivandrum. So, if it is a tuberculoma, if you're going to take a tissue out, it is unlikely that IPSAR has. We work closely with him, Thomas IPSAR in Trivandrum. He has done multiple surgeries for tuberculoma. After, like Kesavan sir said, after 2 years, I mean, if the patient is not responding, he again gets the neurosurgeon to do one more surgery and take tissue. But that is a very difficult scenario. So if it's a abdominal surgery or a spinal surgery or a tuberculoma surgery, you may not get a second sample. So such precious samples, in the beginning itself, better to send the sample to IRL Trivandrum, where they will take for liquid culture, LPA, all the tests will be done together so that you don't miss a chance in that.
Dr. Sanjeev, a few years back, around 6 years back, we had a girl, Vishwana. The father was HIV.
I remember that child.
Died,
I remember the father and the child.
And the father died, and she had this tuberculosis. And initially, that was discussed with the state level, and we decided to put on this resistant regime, and she tolerated. We are all doubtful whether she'll tolerate the drug. And all the 6 months, perfectly all that she tolerated. And the follow-up also, after 1.5 years, we lost her. Actually, the CNS problem, some lesion somewhere in the hypothalamic area, she developed, and that didn't respond. So if it was now, at that time, there was no chance of molecular testing, and the drug, your drug were not available. She lost her. And recently, Dr. Murli knows there was a case of a 16-year-old child with such a
13-year-old boy. 13-year-old boy.
13-year-old boy. I don't know the follow-up. I've seen the case.
We are presenting that case tomorrow, sir, and we have seen the follow-up X-rays. Very good clearance in the X-rays. At least the lung lesions have cleared very well. The child had abdominal TB as well, so the lung lesions have cleared well on X-ray. Very good response after the initial, cardiac events and all that. Now the child is doing very good. So children generally tolerate the drugs well, and Kesavan sir reminded me that the first case of MDR TB that I diagnosed in Kerala among the programmatic set of 2008. So we used to do solid culture there. So our pediatricians, Lalita madam and all came and said, Sanjeev, this is clinical diagnosis MDR TB. So I said, madam, no clinical diagnosis MDR TB. You have to get bacteriological diagnosis. And then we sent for a culture. So those days we were doing solid culture. So solid culture came as positive. Then we sent for susceptibility testing to Chennai, like Ananda sir said. Chennai, the result came in 3 months. So then I went back to madam and said, madam, we have diagnosed MDR TB. Now I can give drugs. Madam said, child is dead. So at that time, we used to lose 10% of our patients before diagnosis. So 3 months for diagnosis, by 3 months, 10% of our patients used to die. So now the molecular tests have made such a huge difference that within 1 day you can have results. So people dying before results and all is a thing of the past. So we have made huge advances in that way. And today we know resistance to a huge pattern of drugs. I mean, 10 years back, I would teach my postgraduates that, in the US, they have a full battery of results and they do individualized treatment. Today, I am doing the same thing in Kerala. So, we have results to, levofloxacin, moxifloxacin, linezolid, clofazimine, all the drugs, I know the results, and based on that, I make a regime. So, in pediatrics, that is difficult because that positive result may not be there. But for all my adult patients, I give regime based on the susceptibility testing. So, that is a huge advantage for me.
Regarding Parvati madam's question and Murli's comment, during the 2020 period, definitely all these pandemic positively affected the most of the communicable diseases, and we were a little bit worried about the drug distribution. But luckily, almost all the the NCD control program went very well in Kerala. Leprosy control, TB control program, anticonvulsant therapy for the disabled child, all went very well, and we had a less number. But as Sanjeev said, we are going to experience the problems result in 2021 and 22, because the confinement within home of the adult tubercles, those cases with kids were more likely. They are going to have more of the problems in the coming years. And in the coming years, more of this, the COVID appropriate behavior is, we are going backwards. All these things we are going to experience in the coming months. And one more thing, Murali, 3 days back, Dr. Murali and medicine people were discussing a case. I was keenly watching that with interest. Some of the parenchymal shadows in adults are creating problems, because the COVID is well known to produce parenchymal long-lasting radiological shadows, which many of them are defined, but few of them are yet to be defined. During the SARS 2002, there was case reports of the lasting parenchymal lesions up to 2 years, and this COVID-19 also is not different. Some of these parenchymal lesion can take bizarre shapes, and that can also, that is likely to persist, and these are likely to create diagnostic dilemmas also. So there's a classical discussion, the appearance of the shadows, but few of the shadows may create confusion, especially in immunocompromised situations. That is a case of a patient on dialysis, renal problems with the nodular shadows and all. They Murali decided to put on ATT empirically. There's a clinical judgment. Definitely a patient dying, hypoxia, we may not get a sample for the molecular test, and we are left with only one thing, whether to put him on ATT or antifungal. These are the disease, and the patient is improving. That's what I know. Murali, your comments?
That patient was I think that patient was a post-COVID patient. Initially, he had all sorts of post-COVID sequelae, the ground glassing and interlobular septal thickening and some consolidation. But later on, the patient had another CT which showed miliary pattern. That is the random nodules with the miliary pattern. So that has to be considered as a new infection, a new happening, and the commonest one is tuberculosis in our setup. So there is no point in withholding anti-tuberculosis therapy for that patient, and we may not be able to take the sample. If the gastric aspirate was there, then it was nice, but that also was not available at that point of time, and the patient was sinking, and we started him on anti-tuberculosis therapy, and the patient is improving. That's what I feel. So the post-COVID sequelae can complicate this scenario at least in adult patients. I was in only adult patients. I have no experience with the pediatric patients in the post-COVID scenario. But there are a lot of lung shadows which can mimic tuberculosis, or it can come along with the tuberculosis as well. So we should have a watchful eye to detect tuberculosis in such situation.
Dr. Suja Aloysius, madam, DMM, madam, any comments? Suja, madam. Suja, madam. If there's no further question, then I request Dr. Sanjeev to propose the vote of thanks.
Actually, Suja madam has something to say.
Nothing, sir. Nothing to add.
Suja madam.
Nothing to add, sir. Okay.
Okay. So thank you, sir. So we are coming to end of today's discussion. We had excellent topics, and we had excellent discussion after the CME. And I will thank all the participants who have joined for today's program, and also thank the Suja Aloysius madam, the DT of Thrissur, for inaugurating this CME, and also thank Dr. Sanjeev sir and Dr. Ananda sir for coming to IAP Thrissur and for giving this excellent talk. Particularly Sanjeev sir giving such a wonderful talk in a very ultra short notice. And also thank IAP officials, Reddy Madam, Mukesh sir, and Manjusha for helping this CME to happen. And also the seniors who joined, like Parvati Madam, Kamalavilli Madam, the Mani sir from Trivandrum, and the Shanavas sir, and other senior faculty from Medical College Thrissur. So once again, I thank all of you. And I hope you all have a wonderful day and wonderful day of learning. And hope you to join on next day. From Thursday, we are coming again with the I-Square TTS infection immunization series. So do join us on that talk on Thursday at 8 p.m. So hope you to see you on that day. Good night and Jai Hind and Jai IAP. Thank you.
Sanjeev sir, നാളെ മറ്റേ ഇന്റർനെറ്റ് physical meeting ആണോ?